So we're here for episode 3 of the podcast with Associate Professor Christopher Penn. Christopher graduated from the University of Western Australia in 1986, working in private practice in West Perth, Western Australia. He's been actively involved in dental sleep medicine since 1990. Christopher's research and practice for 30 years now have been focused on the efficacy and dental side effects from the use of mandibular advancement splints. His collaboration over that time has been primarily with the Western Australian Sleep Disorders Research Institute and the Centre for Sleep Science. Christopher has held office as co-chair of the Orofacial Special Interest Group in the Australasian Sleep Association and is currently a member of the clinical committee. He is an associate professor at the University of Western Australia, being founder and dental coordinator of the Graduate Certificate in Dental Sleep Medicine, and is a member of the ASA Dental Sleep Medicine Accreditation Committee. Thanks for joining us, Christopher.
Yeah, thanks for the invite, Job.
So I'm going to get started and ask you the questions, mate. So can I ask, what does a typical patient workflow look like for you?
Okay. So typically, because I've been doing it for so long, typically patients come to me by referral, usually from a sleep specialist. And in Australia, a sleep specialist is most commonly a respiratory physician who's done further study or a fellowship really in sleep. So they're like a physician. We do get quite a few referrals from ear, nose and throat surgeons, and we get limited referrals from general practitioners. What's interesting in what I've just said is that at no point did I say that I actually look for patients with sleep disordered breathing, but that doesn't mean you shouldn't, and it doesn't mean that I don't, because I do. But generally my workflow is referral based, and that's probably because I've been doing it for so long.
So when you have a patient referred to you from a specialist primarily, and then they will already be diagnosed, that patient, right? So the specialist has diagnosed the patient and they've referred to you under the treatment guide of providing the patient with a oral appliance, essentially.
Correct. So generally, you would say all patients who are referred to me have had a sleep study. Now that could be even if they presented as their presenting primary complaint as being snoring, they still have a sleep study, because it's impossible for anyone to determine whether a patient has underlying sleep apnea. And of course, as you may or may not know, sleep apnea untreated has many consequences. So it's quite irresponsible really to treat a snorer with an oral appliance without proper diagnosis. So the patients are referred to us. We know their severity of sleep apnea, whether they have it or not, the significance of their sleep position, whether they desaturate, etc. during sleep, their oxygen levels desaturate. And so we have a full picture of what we're treating. So that's generally how the flow goes. We then, of course, treat them and then we follow them up. And the most important part of the process is the follow-up, because in the Australian ADA guidelines and the APRA guidelines, provision of mandibular advancement splints is in the scope of practice of every dentist. But unfortunately, it's based on every dentist having the ability to take 2 impressions of someone's teeth, take a protrusive bite and insert 2 bits of plastic. So if you use that as your outcome criteria, yes, every dentist is suitably qualified to do that procedure. But where the actual work starts, where the requirement to have advanced knowledge is in managing the patient and making sure that bit of plastic controls the snoring and controls any underlying sleep apnea, and then to follow up the dental side effects, which we know happen long term. So it's all about managing the patient. It's not about putting 2 bits of plastic in their mouth. So our workflow is based on that outcome.
Awesome. So you would see a patient for impressions or scan, intraoral scan, doing the bite registration, this sort of stuff. And then once you've fitted the patient with the MAD, from there, how many times would you see the patient again? And are you seeing them again like annually, or is there a regular routine? I mean, these might also be your general dental patients, that, you know, presumably as well, that you might see for 6 monthly checkups and things like that. How do you get them into that cycle, and you know, what does that look like for ongoing?
So at the initial consult, they're informed of that workflow. So exactly what I explained about follow-up and about that we're outcome driven. We're not driven by selling a piece of plastic, a splint. We're driven by an outcome. So everything we do is to achieve that outcome. We're also being very careful not to allow uncontrolled side effects to occur. So in my protocol, so there's different protocols and there are no rules. Generally, most dentists would issue the mandibular advancement splint, inform the patient how to adjust it, what outcomes to look for subjectively, and then they'd review them most likely at 1 month, probably 3 months, and then 1 year. In my protocol, I see all the patients at 2 weeks. And that's because when we wrote the paper in 1999 about dental side effects, it seemed like you could pick them up at 2 weeks, and then they were very reversible. So jaw repositioning, etc., was quite manageable and reversible. So I see them at 2 weeks. I then, if they're doing really well and there's no hint of bite change and they're getting symptomatic improvement, I then review them at 6 months or 3 months. So if they're not doing well, I see them again at 3 months. And then if they're doing well, I'll see them at 6 months. At that time, either 3 or 6 months, we're usually referring them back, hopefully for a repeat sleep study to check the efficacy, because there's 2 ways to monitor outcome or efficacy. One is subjectively and the other one is objectively, of course. So objectively means to put them through a sleep study, either level 1 or level 2. It's probably not that important to have a level 1 study as a treatment study. A level 2 study is probably adequate. So you put them back through that study and see how they're going. If they're not getting the outcome that's desired, then of course that requires further adjustment of their mandibular advancement splint. And we go through that. Once we've stabilised their outcome, yes, we see them yearly. Generally, the aim is to get them to yearly visits where we check again dental side effects and medical outcomes. So it's really the mindset you've got to have with this is you're using a dental appliance to treat a medical condition. It's not a dental appliance to treat a dental condition.
Perfect. So that's, yeah, I think that is a really important point. You know, that seems to come up a lot, is that we need to be treating the condition, and that's really, you know, your role in the care of that patient. So you touched on it briefly just then. So when you are titrating a patient, so to speak, what do you need to consider, and what should a dentist be considering when they are? I know that you talked about doing follow-up studies, follow-up PSG. Objectively, what are you looking at, and what's important to understand for titrating patient?
Okay, so really, really complex question. So I say to patients, I say to everyone, if I give a lecture, I'll say there's 2 holy grails in this area. Now, I don't know if Singaporeans know about Monty Python, but if they don't, they need to be educated better, and they have to go and download the Holy Grail and learn what the Holy Grail is. But in this area of treatment, there's 2 Holy Grails. One is how to assess who a mandibular advancement splint will work in, and the second one is how far to protrude the mandible to get the desired outcome. So forget the first one. There's just so many parameters that would indicate who will do well with mandibular advancement splints, but it's impossible to work out, and there's not one single study that tells you a particular patient has 100% guaranteed outcome, like, and 100% guaranteed they will get the desired outcome. So forget that one. But the other one, the working out where the jaw position should be, we can do some quirky things using apps, which we do, basically using sound, because we do know from the research that if you're a snorer who has sleep apnea, as your snoring decreases, your sleep apnea decreases as well, but you can't quantify that. So you can't actually say, oh, your snoring's dropped to 0, so now your apnea is 0. You can't do that. But at least it gives you some guidance as to where the sweet spot may be. But ultimately, everything goes back to a sleep study. But within the sleep study, the most important parameter there is the oxygen desaturation index. So actually seeing what's happening to the oxygen. Now, the caveat on everything I just told you is that there are sleep apneic patients who don't snore, and there's snorers who don't have sleep apnea. So it's a little bit tricky. There's also patients with sleep apnea who don't really desaturate, which is amazing as well. So there's a lot of caveats on what we're saying, but this is why you have to have a deep understanding of the area. It's a complex area, and there's no rules. You know, it's actually understanding what you're treating is the most important thing here.
That was a great answer, mate. I think, that just drives home the point that people really do need to continually learn and educate themselves on what they need to know post treatment, plus after diagnosis, even before they start treatment. So we haven't really touched on this too much. What does an effective multidisciplinary team in sleep apnea look like? And I guess secondary to that, how do you effectively communicate with the team to get the best outcome, knowing that, especially as a dentist, you need a lot of dental tools and things. It's not always likely that you're going to be all working together, especially with a specialist who might also have their own, equipment that they need, and bring it all together, is hard. So, usually it's multi-centered. So how do we manage that effectively, and what does a good team look like?
Okay, so the other thing I didn't put in the bio is it's really hard to write a 30-year bio. So one of the things I didn't put in there is that we actually do run a multidisciplinary team meeting in Western Australia. And that involves a sleep specialist, an ENT surgeon, a maxillofacial surgeon, and 2 dentists. Well, yeah. So that's our team that we meet with. Now, that's different to what you're talking about, I believe, but I also believe that everyone should have an MDT. They should have a multidisciplinary team where you can take what we call refractory cases. So they're cases that don't respond to treatment, or that you are having difficulty getting an outcome. So that might mean that they require one of the other specialties to intervene to get the outcome that is being desired. But really where your question's coming from is how I'm really sorry, I'm going to have to do a COVID. Not allowed to do that with COVID. Not allowed to rub your face. But no, it's true. If you get caught rubbing your face in Australia, you'll have your hand cut off. So that was funny. So within your question, how that looks to us is, after the doctors referred for treatment, and we've, by the way, nearly everyone who is referred to us has failed CPAP or declined CPAP. So everyone in Australia pretty much gets offered CPAP. I've got to tell you that. And so that might be a different model to every other country, but certainly in Australia, everyone's they attempt CPAP on everyone, or at least offer it. So you referred to the dentist, and then you treat the patient, and usually what we do, we send the first letter to acknowledge we've seen the patient and make sure they're dentally suitable, because that's the other thing. It's not necessarily whether they're suitable for an outcome for their snoring and sleep apnea. It's also whether they're suitable dentally, like having enough teeth and their periodontal condition and blah, blah, blah. So once we've done that, we write to the referring doctor, and I guess I'll go back to the non-referred patients in a minute. But we write to the referring doctor and we inform the referring doctor we've seen the patient and we're going to be going ahead with treatment if the patient is happy with that. So then we do that. We go ahead and we titrate it and we get our subjective outcome. We then write another letter back to the referring doctor to inform him of how the patient's travelling, whether they're getting symptomatic improvement, how they're going with their side effects, etc. If we think they're then ready to have their repeat study, we then ask the doctor to organise that at their discretion. Because in Australia, the respiratory physician is the top of the tree. So we have the respiratory physician, then below the respiratory / sleep physician, we have the ENT surgeon and the dentist. So the ENT surgeon and the dentist are equal because really they just treat, right? They have limited knowledge of sleep, to be honest, compared to a sleep specialist. And so we're on the same rung as them. But we do cross-refer. So the dentist will refer to the ENT and the ENT will refer to the dentist with or without the sleep specialist. But the sleep specialist is the top of the pile when it comes to expertise, because of course there's like 180 sleep disorders. Not everything's obstructive sleep apnea. And so that's why it's important to have a bigger knowledge of sleep, even as a dentist, because there's no point treating a patient who can't sleep because they think they're having obstructions when in fact they've just got straight insomnia, which is a completely different treatment path. So the importance of having the multidisciplinary team is that you write to someone, inform them, so you have this dialogue. You then might write to that doctor and say, you know what, I think the sleep apnea is under control. I think you should test it, and if it's not, I think we should send you the patient to a clean psych and get some cognitive behavioural therapy for their insomnia. So that's how it all looks within Australia. But of course, we're limited in what we can do by Medicare, because in Australia, a dentist can't refer to a sleep specialist because they're a consultant physician. So it has to go through a general practitioner. The general practitioner then has to write to the sleep specialist. So that's why I don't go looking for patients that much, but if I do, that's what I have to do. I have to send them to their GP to then decide where they're going to be sent, to which sleep specialists, etc. The other problem is that in Australia, a dentist can't refer for a sleep study and attract a Medicare rebate. That has to be done through a GP or a sleep specialist as well. So we're quite restricted. So our pathway in Australia is going to differ dramatically from the pathway in Singapore. And of course, from what you've told me, Joel, about Singapore, I'm moving there because I would have so much more freedom of practice if I was in Singapore. And really, Singaporean dentists should be able to provide a much better treatment outcome than an Australian dentist based on their ability to get these services without government sort of intervention.
Yeah, I think they certainly can. They have more scope in Singapore and other Southeast Asian countries and other parts of Asia where you're able to be more at the center of care and not restricted by nuances in reimbursement. That you might see in Australia where it's a little bit more rigid based on the way that they structured the reimbursement. So it is a bit more, and I think the mentality in Southeast Asia and Singapore in particular is that there is a tendency to pay for healthcare, as
Yep.
opposed to in Australia, where even wealthy patients potentially might not pay for services that they actually really need, because they're thinking, oh, I'm entitled to this service because of Medicare and I'm paying my Medicare levy and that sort of stuff. So the differences there are interesting. And I think it's a really good point that you raised, because having the scope and the freedom to order these tests just means, that really what you need to do is upskill yourself so that you know how to treat these patients, get yourself to a level where you can do it, and it'll open, high or a volume of doors to treatment, and capacity to see different types of patients by getting educated in this field.
Correct. That's exactly right. And yeah, well, that's why I started the degree, because I just got frustrated that dentists were putting in these splints and not getting outcomes. And of course, the downside to that in our world is that it then gives a negative opinion to the sleep specialist, because they're going, well, I sent to this dentist that's in their normal scope of practice. The outcome was really bad, so therefore splints are a useless tool. It was that sort of thought process. And of course, it's not a useless tool. It's absolutely the second most effective tool after CPAP, and way ahead of surgery. Certainly for us, surgery is what we call an adjunctive treatment, or a salvage procedure. It certainly is never the first line, and it can work as an adjunct, and hence the importance of a multidisciplinary team. Ideally you'd have a sleep specialist, a maxillofacial surgeon, and an ENT surgeon, because maxillofacial surgery also has very good outcomes, and certainly that's an option as well. But obviously you'll go for the thing that's less invasive, which means CPAP or splint, which is just a no-brainer. That's really where your primary treatment should be aimed.
There's a high volume of patients that fail CPAP too. So it's not like going into, even if you're talking to sleep specialists that aren't going to use you for a oral appliance as for first-line treatment, there's going to be 50 to 60% of those patients in 2 years' time that actually won't tolerate CPAP, or will be no longer using. So I think that, that's where there's a huge opportunity as a starting point for patients to be referred to, trained dentists. And there's secondary to that, they're able to, in markets like Singapore and Hong Kong, Malaysia, they're able to screen their own patients and refer them directly to have a study done, which is, a unique opportunity compared to other parts of the world.
Yeah, they're really, like I say, I think I'll come and live there, because in my world I'd be in heaven, mainly because I think I know enough to be able to. Well, I basically did another degree. I did a sleep science degree, which allowed me to be able to read sleep studies and whatnot. So, I'd be so happy in that environment where I could read my own sleep studies, and it'd be great. But never mind.
I guess the next question leads on from there, is how can newcomers to OSA treatments be more effective? And what do you see as common mistakes, especially when people are starting out? What are the common mistakes that young or newly trained dentists are making in the field?
That's a tough question, because my answer is they don't know what they're doing. So that's the problem. Like, they just don't know what they're doing. They just stick it in and go for it. So I think one of the biggest things we see is managing side effects and not informing patients that there are long-term side effects, and that it's a question of weighing up the negatives and the positives. So, it's a risk-benefit discussion that has to be had. So it's the initial consult of predicting what's coming is the problem. The other thing is, there are no good titration protocols. So, 99% of, well, nearly all dentists who haven't done a further education in the area really don't know the nuances of titration, and there's a lot to be learned there. So it's surprising, really. Generally the trend is more is better. So the more you protrude the mandible, the better the outcome. But that can be fraught with danger as far as side effects, and then of course outcome as well, meaning the effect on snoring and sleep apnea. But as a general, so it's mainly those fine-tuning problems. That's where they all fall over, because, as I keep saying, it is so basic to be able to put a splint in. I mean, everyone in dental school, first year probably, is taught how to scan or take an impression. That's not hard. Then you take a protrusive bite. There's enough gauges around to help you do that really well. And then there's a fitting. But like I keep saying, where they fall over is in that ongoing management and the ongoing nuances of adjusting the splint to get the outcome. So again, I go back to education, and that's why I wrote that degree, to teach that, to teach all of those minor things. And the other beautiful thing about the degree is, even if it's not written, there's access to the faculty, and that access we give for life. So I still have our original cohort of students who graduated in 2012, so 8 years ago, still ringing me when they have tricky cases. So it sort of sets up a collegiate type arrangement where you all help each other, because ultimately, the whole thing behind all of this is the patient. So it's all about making the patient's life better. That's what drives all of it. And so, if it means you need to do more education to do that, then you've got to do it. If it means you have to ask someone old how to do something, then you've just got to do it. You shouldn't just go through a process and think that's it. Put a splint in, happy days, because that's not how it works.
Yeah, I think you highlighted the point that having a mentor and having somebody to bounce, your ideas and thoughts and problems off with is one of the most critical components after you get training, so that you can, I guess, do the right thing, but more so understand what's actually happening with the patient when you're treating them. And I guess that's really interesting that as part of the course that you guys are doing, you have, still graduates that are talking to you all the time and bouncing ideas off you with cases and how to actually treat these patients, which is pretty awesome.
Yeah, well, it seems to be working well. We have, I think we're up to about 38 Australia-wide, which is quite a lot for a very small area of dentistry that, isn't a specialty, and it's a niche area, really. So yeah, it's quite crazy. And of course, in Australia, it's fairly expensive to do the course as well. So it just shows you how people value that education, So people do pay for it because they do get benefit. And like I say, the patients get benefit. So, what we're doing now within the Australasian Sleep Association is doing an accreditation type. It's like an exam, I guess, where you present cases and do a multiple choice exam, and at least it tells the sleep specialist that there are people who know a little bit more than the average. So, some of them, if they don't pass the exam, they'll probably come on and do our course. But most of them think they probably can pass the exam, so they'll probably sit it initially and then see how they go. So there is reading material associated with that as well. So they could do that as well. And that would be open to anyone who's a member of that ASA, we call it. So that would be Australasian, means there'd be anyone in Singapore could also join and could potentially do that as well.
Wow, that's really interesting. So the last question I was going to ask, which kind of leads on from what we've been talking about, is what's the best piece of advice you could give someone starting out in the field?
Yeah. Well, I'll tell you a story. So I had been doing dental sleep medicine since 1990, and then in 2010 is when we started writing the course. So what was that? How many years later? 20 years later, we start writing the course, and my wife, who's a dentist, and my daughter, who's a dentist, my wife had no interest at all in all that work I did in sleep, all the research and flying around the world, going to meetings, no interest. But when we did the course, mind you, she's Singaporean, so it fits into the mindset that she said, well, you know what? I'm not even going to put a splint in anyone's mouth till I've done a course, which is hilarious after I'd been doing it for 20 years. And you'd think she would have learned something from me, but no. So she had to do her course and get a piece of paper. And then my daughter, who's a dentist, really did dentistry because she really liked the sleep aspect of it. So she's also done our graduate degree. And my words of advice are get education before you go stuffing anything up, because basically there's enough information, there's enough courses in the world, there's enough information. Just get education, because it'll make your life so much happier, and you'll go in with your eyes open rather than fumbling and wondering what you're doing and why things aren't working out, and how you got to manage the side effects, etc. So it just makes your life more enjoyable. I mean, I've done all that. I've done all the heartache because I was there at the very beginning of dental sleep medicine. So I've made all the mistakes, and I've seen, what can go wrong. And really, if I'd had a degree to do 30 years ago, I would have done it in hindsight. And certainly for my wife and daughter, they're proof that really education's the key to make your life easy. So you could dabble in it. You could. I think the most important thing is to make sure that you're going to have a good association with a medical practitioner, whether it's a GP with an interest in sleep, an ENT surgeon with an interest in sleep, or I don't know, Singapore, if you have sleep specialists, but certainly a respiratory physician would be better than nothing. But really you want to tie yourself in with someone who has an interest in sleep, so you can work as that team that we were talking about, that sort of multidisciplinary team. Because really you don't want to really be responsible for treating this medical condition by yourself. You don't want to be when that person has a stroke and they go, well, did no one pick up their sleep apnea after you've put a splint in for a snorer? You don't want to be that guy. You want to be talking to the medical practitioner, and you want to have your sleep study, and you want to make sure you're doing best practice. So that's all I would say. If you're going into the area, get educated, tie yourself in with someone medical, make sure you've got someone to report, because you don't want to be responsible for it all by yourself.
Fantastic, mate. I think you have a lot to offer in terms of advice, but I think the importance of being educated is a real highlight of what you've spoken about today. And I think if people want to learn more about the course that's run in the University of Western Australia, we'll provide a link on the video so that you can go and check it out. And also, I guess we can put them in touch with you to chat about what the course is about as well.
Yeah, sure. Because that's my job in a way. I work privately and at uni, so I'm more than happy to speak to anyone about that.
That's awesome. And we should have some bits and pieces, some other learning opportunities, and we might hear from you a little bit more in the future. So thanks very much for your time, mate. Really appreciate it. And I'm sure that there's going to be a lot of people that have taken away, some good information today.
Lovely. Thanks, Joel.
Good on you, mate.
See ya.